Next, I would like to introduce Daniel Sellen from the University of Toronto.
Tried to present the baseline results on a 4-country multi-year. So just to give you the background, there is a continuing focus, particularly by Global Affairs Canada, on addressing at scale, through large-scale integrated programs, the continuing problem of stunting and wasting. And recent data, this is World Bank data from the 2018 report, remind us that of all the kids who are stunted today, 55% of them are in Asia, and about 39% of them are in Africa. And of all the kids stunted, all the kids wasted globally, fully 2/3 are in Asia, mostly in South Asia, and more than 1/4 of them are in Africa. So many of us here know the high prevalence countries, but that is where programming is being focused. And if we look at women, many indicators we could show you, but take anemia. Of the women globally who have iron deficiency anemia, about 29% of non-pregnant women and 38% of pregnant women in the 15 to 49 age group are anemic, and it affects still more than 500 million women of reproductive age worldwide. And again, they are clustered in the regions that we just identified. So the project that we have helped to evaluate as a research consortium is called the ENRICH project. That's the short acronym for Enhancing Nutrition Services to Improve Maternal and Child Health in Africa and Asia. I won't be presenting the basket of interventions, but they include everything from health system strengthening to community-based efforts to build gender empowerment, microfinance, agriculture, and uptake of antenatal and postnatal services, and are complex and tailored to each set of countries. So this is a maternal child intervention supported by Global Affairs, and the key thing to note is that over the next 4 or 5 years, the total spend will be 47 million Canadian dollars, which is a little less than it was last year, but is still a big chunk of change. And the intent is to improve the lives of more than 2 million direct beneficiaries, over 740,000 children and 835,000 women. And a number of indirect beneficiaries. And the countries where this is being done are Myanmar, Bangladesh, Pakistan, Tanzania, and Kenya. And the programs are being targeted in high stunting prevalence regions within each of those countries. So what I'm going to be talking about is baseline cross-sectional household survey data conducted in 4 of those 5 countries back at the end of 2016, before the implementation of activities began in March 2017. So just for those of you who know the 4 countries I'm going to mention, just to give you the location very quickly. In Bangladesh, this work took place in the furthest northern district, Takagawan, in Ranjpur district. For Pakistan, the work took place in Sukur district in Sindh province. In Kenya, didn't come through too well, it's the Western Highlands area of Elgeyo Marakwet. And in Tanzania, it's the 2 central areas in Shinyanga and Singida, which are rocky and savanna types of environment. And the objectives of this study that I'll present today very quickly were to estimate the level of public health significance of stunting and wasting in all of these areas, and then to examine some of the indicators we've been looking at for the immediate and underlying causes of undernutrition in each local context. And we're basically adopting the very well-known, very long-standing framework originally from UNICEF, revisited by Black and others in Lancet in Maternal series from 2008, but essentially looking at disease and dietary adequate intake as the primary or immediate causes of maternal and child malnutrition, and then looking at the underlying causes, including indicators of household food insecurity, caregiving, and household environment. So very fast, we now have good information on these 4 of these areas. The work in Myanmar was done by the Rangoon School of Public Health using similar tools but independently, so we won't be presenting those today. The baseline survey approach was essentially using a 2-step sampling selection with population sampling units at the village level where health workers were active. We developed a very representative sample for 3 age groups of children using household listings, and the achieved sample sizes were over 800 or 900 households cluster randomized in each area. The first result is that in all 4 of these countries, the stunting rates were high and of high public health significance, and in Pakistan in particular, very high rates of wasting. And so clearly there's work to be done here. There were big gaps between actual and recommended breastfeeding practices in every country. And so what I'm going to show you is a few slides here where the bars are to do with negative indicators, which are intended to be brought down 3 to 4 years through interventions. And you can see that, for example, for this indicator in Pakistan and Kenya, the number of proportion of kids who don't start to breastfeed within an hour is the highest, and similarly, non-exclusive breastfeeding rates are highest also in Kenya in the first 6 months of life. So these poor breastfeeding practices among a high proportion of households are matched by even higher rates of complementary feeding practices, which currently at baseline don't meet minimum dietary diversity score cutoffs, minimum acceptable diet cutoffs, or consumption of biofortified crops within the last week. And biofortified crops of various kinds are being introduced in each area. So clearly the baselines show that there is room for driving down the negative indicators of the immediate causal factors in those stunting and wasting rates. If we look at the actual and recommended maternal dietary diversity and iron folate intake data, same story across these sites, very high levels of mothers who do not meet the minimum dietary diversity score or do not consume iron folate supplement. We'll wind up now. The child morbidity indicators are high, so there's a lot of illness in the community. So with that, since time's running out, we can also very quickly summarize that food insecurity scores are high, that sanitation resources such as latrine use are low, and there are a number of health service weaknesses. So these are our baseline results, and we are launching now our plans for the midlines to assess changes in these indicators beginning at the end of this year, 2008, after about 18 months of exposure to a basket of interventions. Thank you very much.